Hello, everyone. Thank you for joining us today. On this month's episode of Wellness Webinar, we'll be talking about aortic stenosis. So, focusing on keeping your heart strong and what to know about a narrow heart valve. Joining us is Dr. Michael Buschur. He's also the medical director of interventional cardiology. So, I'm really excited to have him. Dr. Buschur, thank you so much for joining us. The floor is yours.
Well, thank you very much for having me. Um, it's nice to be able to talk to everyone today. If you have any questions that come up, please enter them in chat and we'll do some questions at the end. Just a little bit about myself. I've been working here at Mount Carmel for about 11 years now. I'm from Ohio originally. I grew up in the Cincinnati area. I went to undergrad at the Ohio State University and then did medical school up at Case Western in Cleveland. And I was at the University of Michigan for residency and fellowship, so for about 9 years. Even though I'm still Buckeye through and through, it was a great hospital in Michigan, and I definitely learned a lot while I was there. All right. So today we're going to talk about aortic valve stenosis. Aortic valve stenosis is the most common cause of left ventricular outflow obstruction in children and in adults. We're going to discuss not only the prevalence of aortic valve stenosis as well as the pathology. We're going to discuss diagnosis of this disorder and finally treatment options, as there's been a lot of evolving options over the last 10 years. In terms of aortic valve prevalence, the next slide will show you what the aortic valve is. So the red dot on the right is right where the aortic valve sits. The aortic valve connects the heart to the aorta. In aortic valve stenosis, the valve itself does not open fully. Inside the heart, the aortic valve is one of four heart valves. The heart valves each keep blood flowing in only one direction. They connect different chambers to the heart. The aortic valve connects the left ventricle to the aorta. When the aortic valve opens, such as the picture of this healthy valve on the left ventricle is able to contract and push blood through the valve. The aorta then carries the blood to the rest of the body. In aortic valve stenosis, calcification builds up on the valve, so it can't open all the way. Over time, this causes the heart to have to work harder and harder to try to force blood through a valve that's just not opening all the way. And eventually, not enough blood is able to be pumped out of the heart with each heartbeat and get to the body where it needs to go. It causes the heart to have to work a lot harder. It can lead to different symptoms, which we'll get into, and even cause congestive heart failure. Now, when we look at the pictures of the valve, there's a progression of aortic valve stenosis. And there's really three main causes of this condition. One is a congenital abnormality. So if you look at the healthy valve all the way on the side of the screen, the valve almost looks like a Mercedes-Benz sign or a peace sign. There's three different leaflets that open and close, and that's what we see in most adults and in most of the world. However, one of the most common causes of aortic valve stenosis is being born with a bicuspid valve. So instead of having three leaflets, patients are born just having two leaflets. Two of the leaflets are actually fused together before they're born. Now, over time, that leads to calcification building up a lot sooner at an earlier age than what we see with the other types of valve issues. And because of that, there's some different treatment options that we use when there's a congenital abnormality for the aortic valve. In the United States, the most common reason for developing aortic stenosis is calcific disease. So as we get older, calcium builds up on the valve and restricts it. Now, this is not from anything patients are doing or not doing. It's just more a part of getting older than anything else. Unfortunately, as it does progress and become severe, there's not really any medications that we can use to treat it. When the valve becomes severe and causes symptoms, then we'd have discussions about different ways to replace the valve. And then finally, rheumatic heart disease is actually the most common worldwide. It's the most common reason for aortic valve stenosis and mitral valve stenosis. We don't see as much of this in the United States. We have different treatments that we can use for rheumatic fever before it can progress and affect the heart. But worldwide, it's still the most common reason for valvular heart disease. Okay, we can go on to the next slide. And again, the three main causes: congenital, where somebody may be born with one or two leaflets instead of three; calcific disease, which is we see a lot here in the United States; and then finally rheumatic disease, which is much more common throughout the world. Now, the progression of aortic valve stenosis is quite variable. In general, the natural history of aortic stenosis begins with a prolonged asymptomatic period. A lot of times, as the valve is in the mild, even moderate, and sometimes even severe progression, patients may not notice a lot of symptoms. So symptoms are kind of one thing that we look at. We also do echocardiograms or ultrasounds to follow the valve closely. In general, when symptoms develop, it's usually as the valve is in the moderate to severe range, which means that we start to have discussions about different ways to replace the valve. Overall, kind of on average, there's been a lot of studies looking at progression, and we typically say about 0.1 centimeter per year. So each year that goes by, the valve area is shrinking by 0.1 centimeter. But again, in some patients, it can happen a lot slower, and it could be that they have moderate stenosis for 20 years and never need a valve replacement. And in some patients, it can happen a lot quicker. There's no great way for us to predict how it's going to progress. There are some risk factors that we look at. Once somebody develops aortic valve stenosis, even if it is mild, there are certain things we can look at that give us an idea of how quickly it may progress. Some of those risk factors are things like chronic kidney disease or renal insufficiency. Smokers, there's been data that smokers have a quicker progression of their valvular heart disease. Diabetes, hyperlipidemia or high cholesterol, and high calcium level. We also tend to see little faster progression in elderly patients, and for some reason more in men than women. We don't have a great explanation for that. What we do know is that once patients develop symptoms, the mortality in anyone with aortic valve stenosis dramatically increases. So once patients develop symptoms, or if they have heart failure, we tend to move pretty quickly to get the valve repaired or get the valve replaced. Okay, we can go to the next slide. This is a huge issue in America because, as everyone knows, the population of Americans age 65 and plus is growing and is growing quicker. Not only is the elderly population is increasing, more people are reaching older ages. What we're seeing now compared to 1980, even in just the last 45 years, the average life expectancy in Americans is gone up a great deal. And in the next 5 years, 20% of Americans will be age 65 and older. So because a lot of the aortic stenosis that we're seeing in America is calcific and is driven by aging population, this prevalence of aortic valve stenosis is increasing quite a bit. Okay, next slide, please. Now, we know that the prevalence of aortic valve stenosis is increasing, but what we've seen is that the treatment is lagging. And so while we're seeing a lot more patients who have this valvular heart disease, it may be that it's being missed or underappreciated by primary care physicians or even by some cardiologists. Because again, it is extremely common and it is happening to a lot more patients as they get older. So we're really trying to make a concerted effort for education for not only patients, but also for primary care physicians with what to look for, what symptoms to watch for, and to reach out to cardiology with any concerns or questions that they have. And that way we can get the patients in as quickly as they need to so they can be evaluated by us. All right, next slide, please. So what we've noticed over the last couple of years, or really the last 10 years, of the patients who do have severe aortic valve stenosis, only about 60% are receiving the treatment in terms of valve replacement that they need. Some of this is due to patients not having any symptoms, and the cardiologist has decided just to watch them closely until they develop symptoms, which is reasonable. But more often than not, it's because they're not receiving the treatment that they should be, whether they're not getting referred or evaluated in time. And these are the gaps that we're trying to correct. So what do the guidelines say for aortic valve stenosis? So taking a step back, the main symptoms that we look for, there's three certain criteria. One is shortness of breath, especially with exertion, or decreased exercise tolerance. So what I tell my patients is, we always kind of look back at how they're feeling now compared to a year ago. If they're not able to do as much walking or as much activity as what they did a year ago, that's a pretty big red flag. And because aortic valve stenosis progresses very slowly, some patients don't really realize the slow progression and how it's limiting the activities that they want to do. But shortness of breath, especially with exertion, is one of the main symptoms. The next is dizziness, or lightheadedness, dizziness, or a feeling of weakness, especially with exertion. To the fact that some people will have to stop, even if they're just walking or going up and downstairs at home, they'll have to stop to maybe catch their balance, catch their breath. And then the final symptom is angina or chest pain. Again, usually more with exertion, but over time, as the valve progresses, the symptoms can happen at rest as well. So anytime any of those symptoms develop, the first test that we'll do is an ultrasound or an echocardiogram to better quantify the severity of the aortic valve stenosis. This will also enable us to look at the heart pumping function and get an idea of how strong the heart muscle is. And when we're doing that ultrasound, there are certain criteria that we look at. And these numbers are, a little more detailed, but we're looking at the aortic valve area. So any valve area less than 1 centimeter is going to be in the severe range. And as we mentioned before, if it's not at the severe range, a good rule of thumb is that each year the valve will decrease in area by about 0.1 centimeters. So that's something that we watch pretty closely. We also look at the pressure difference across the valve. When the valve isn't opening all the way, there's kind of the heart is working harder and harder, and it increases the amount of pressure that it exerts to try to force blood through this valve. And we'll actually see a pressure gradient in front of the valve versus behind the valve. So when the heart is working hard, that pressure is going to go up. And then on the other side of the valve, where it's not opening all the way, the pressure is going to be a lot lower. So that gradient is something we look at. But again, in anybody who develops symptoms, we're going to be much more aggressive with the testing that we need to do and the discussion of treatment options. Okay, next slide, please. So what are the obstacles in the patient journey? Again, the biggest obstacle we're seeing is symptom identification. So we're really working with patients to let them know what symptoms to watch for and to really have them be honest with themselves in terms of how they feel when they're exerting themselves, or maybe as the symptoms are slowly developing, they're just not doing the amount of activities they used to. A lot of times the patients will go see their PCP first. So we're doing education with primary care physicians in terms of what they should be listening for when they auscultate the heart in terms of different murmurs, what symptoms they should be screening their patients for. And it can be difficult in patients who are sedentary, as that's a big problem that we're seeing in the United States, is a lot of patients aren't doing any exercise or really any kind of activity. So it's hard to judge their symptoms when they're quite sedentary. So once this has been detected by the primary care physician, or they're concerned enough about symptoms, they'll get sent to the cardiology office. And typically, cardiology office may be a general cardiologist, they may be a specialist, but we'll get them in, we'll get them evaluated, and usually, again, starting with imaging. An echocardiogram or an ultrasound is the first test that we do to better quantify the severity of aortic valve stenosis. After that, we have a heart team. So the biggest part of aortic valve replacement, or really any type of structural heart treatment that we offer, is part of this heart team. So we have a shared decision making where an interventional cardiologist such as myself, as well as a cardiothoracic surgeon, and a lot of times nursing staff and anesthesiologists with the patient and the patient's family, will sit down and have a discussion regarding what the diagnosis is, and then discuss treatment options, whether that would be a minimally invasive procedure or if open heart surgery would be best served for the patient. But this shared decision making and open heart team is really the crux of what we're offering here at Mount Carmel, and the best way for us to best serve our patients. When patients do undergo the TAVR procedure, even open heart surgery, afterward we see them back routinely in the office, usually at a week out, and then a couple weeks after that, as we do serial exams and make sure that patients are recovering from their therapy. Okay, next slide, please. And again, when we're looking at asymptomatic patients, we talked about what symptoms to watch for, but if somebody doesn't have symptoms, when do we consider aortic valve replacement? And again, this ties into a referral to the heart team. And at Mount Carmel, we have an excellent heart team involved with our surgeons, our anesthesiologists, the interventional cardiologist, where we really personalize our decision making and our therapy for each individual patient and have discussions with them and their family. But if somebody doesn't have any symptoms and we know based on ultrasound that the valve is severe, there could be a couple reasons. One is, maybe they're not active and it's hard to know if they're having symptoms when they're sedentary. Or a lot of times we'll see patients who are actually quite active. They feel fine. They're doing all of their activities that they want with no limitations. But then there's a couple things that we look at in the echocardiogram. If we see that their ejection fraction or the ability of the heart to pump strongly, if that's starting to diminish, then we have discussions about getting the aortic valve replaced. The problem is once the heart pumping function gets weak, then we sometimes, even with a new heart valve, it won't regain its strength. So once the heart muscle loses its ability to work hard, we have discussions regarding aortic valve replacement pretty soon. The other thing that we look at is not only if the heart muscle is getting weak, but if the heart muscle is dilating or if the heart is starting to go into congestive heart failure. Even if patients aren't having a lot of symptoms, those are pretty big red flags that we don't want to wait too long where there could be irreversible damage to the heart. All right, next slide, please. So looking at, and we'll get into the details about treatment options later, but when we're looking at treatment options, open heart surgery has historically been the way to fix aortic valve stenosis, and it works great. There's a couple different valves that we can use with open heart surgery, a bioprosthetic valve versus a mechanical valve. Now, in young patients, a mechanical valve tends to be the way that we like to proceed. Whether we do open heart surgery or TAVR, when we use bioprosthetic valves, that's also what a TAVR uses, the valves last about 10 years on average. So not only as we're planning treatment options, are we planning what we're going to do in the short term to get the valve fixed, but we have to think about what we're going to do in 10 years to replace the valve, again, if it fails, with knowing that the average lifespan is about 10 years. Now, in young patients who are younger than the age of 50, usually it's from a congenital bicuspid or unicuspid valve that they're having severe aortic valve stenosis. When we put in a mechanical valve, it's a permanent fix. Now, mechanical valves have pros and cons. Anybody with a mechanical valve has to be on pretty potent blood thinners for the rest of their life, but mechanical valves last forever. So these are all discussions that we have with each patient and as part of the heart team, knowing that there's different criteria for each patient, and we have to look at a variety of factors without just having a one-size-fit-all approach. All right, next slide, please. And again, going back to the referral basis, having patients bring up their symptoms with their primary care physician and getting sent to general cardiologist, this is really very important in driving this shared decision making. Having collaboration between cardiology, which at Mount Carmel is our heart and vascular team, as well as our primary care physicians, knowing that they can reach out to us with concerns or questions. And when they are worried, we can get the patient in very quickly. And that way we can ensure that every patient gets offered the treatment that's right for them. Again, looking at the multidisciplinary heart valve team, this is something that has been new really in the last 10 years. It used to be that open heart surgery and interventional cardiology were separate and they would kind of do their own things. But what we found is that having the capacity to offer an open heart team has really been great for patient care and enables us to stay on the cutting edge with therapies that we can offer. And kind of a nice summary slide looking at going from visiting with primary care physicians or to the general cardiologist, doing the ultrasound with the echocardiogram to confirm the severe aortic valve stenosis, and then our heart team approach as we come up with a plan with TAVR versus SAVR. Now, talking more about treatment options, again, surgical aortic valve replacement works very well, and historically this was the only option that we had. Transcatheter aortic valve replacement was actually first performed in 2002, sorry, not 2022. Initially, the minimally invasive way, or the TAVR approach, was only for high-risk patients who were deemed too high risk for surgery. And that's how we first started comparing TAVR versus open heart surgery. Over the last 20 years, We've actually gone from looking at patients who are too high risk for surgery to patients who are moderate risk and even low risk. And with each successive trial that's gone on, we found that TAVR holds up remarkably well, and in most cases, even better than open heart surgery. The concept of TAVR was first introduced in the 1980s. The idea being, what kind of valve can we put in a minimally invasive way that would still help with aortic valve stenosis? In 1989 was the first animal implantation. They actually used a balloon expandable valve, and we'll talk briefly about the different types of valves that we use. And then it wasn't until 2002 that the first TAVR was performed on a human in France. Beginning in 2007 is when we really started focusing on randomized control trials with patients who are too high risk for surgery and could only have the minimally invasive approach or the TAVR approach. And then over the last 18 years now, we've compared it to the moderate and low risk patients. Currently, there's over 100,000 TAVRs performed yearly in the United States. So when we meet with the heart team, there's a lot of things that we look at. Each individual, as you can imagine, everybody's heart is a different size, and everybody is going to have a different size aortic valve and ascending aorta. So the orange line here is kind of the sinotubular junction, and the green line is where the aortic valve sits. So when we're looking at putting in a new heart valve, whether it's with open heart surgery or TAVR, there's actually about 12 to 15 different size valves that we can use. So before we jump into any procedure, we get a CAT scan. CAT scan, easy enough test. Patients lie down, it goes in, goes out, but the CAT scan takes very detailed measurements of their aortic valve, their aorta, and also what we call the sinuses, or the area that's kind of around the valve. This tells us a lot of information. It helps us figure out what size valve we need. It'll tell us if we can safely fit in a TAVR valve or if we have to consider open heart surgery, because in some patients, there's just not enough room to put in a TAVR valve and we have to do surgery. It'll also help us plan for the future. So in some of our younger patients, if we know that we can safely place a TAVR valve now, the CAT scan will give us the information we need. So in 10 years down the road, we have a plan to do another valve if we need to. What we don't want to do is place a TAVR valve now and then in 10 years say, oh, you know what, now we need open heart surgery, where 10 years later, the patient's going to be at a lot higher risk for any kind of complications from surgery. All right, next slide, please. And again, this is another picture kind of looking at the aortic valve and the annulus and how complex it is. Just where the valve is interacting with the aorta, with the sinuses, which are almost the red structures that we see around the valve. And this is, again, where the CAT scan is extremely important. The aortic valve, while it's sitting there connecting the heart to the aorta, it's very close to the coronary arteries. The coronary arteries actually come off the aorta just above the valve. So we also want to make sure we don't have a valve that will cover the coronary arteries. That would be catastrophic. The aortic valve interacts with the left ventricular outflow tract as well as the septum. And in some cases, it can even interact with the mitral leaflet, the mitral valve. So it's a very complex, relationship where it sits. And that's what makes the discussions that we have with the heart team even more important, so that we can do not only what's best for the patient, but what's going to be safest and give them the best long-term outcome. Thank you. So these are two of the main types of valves that we use, and I have some videos that we'll show in a second. On top is what we call a self-expanding valve, and the bottom is a balloon expandable valve. In these pictures, the top one is made by Medtronic and the bottom one by Edwards. At Mount Carmel, we use both. We need to have all the options available because, again, there's a lot of different anatomic issues that we see with patients, and in some patients, we can only do one valve or the other. So having the option for both types of valves is really important. Overall, we probably use more of the Edwards valve, the bottom valve, than we do of the top valve, just because it fits our patients better, and we've had really outstanding outcomes. So when we look at the top valve, as you can see, it's a lot. The frame or the cage around the valve is a lot bigger, and the one on the bottom is smaller. And I'll show you pictures about how they expand. And when we say balloon expandable versus self-expanding, it's really just how we deploy the new valve. When you look to the side, the little pink going up and down on the pictures on the left, that's the existing heart valve. So the amazing thing about TAVR is we do not have to surgically remove the failing heart valve. The new valve actually just sits inside the old valve and pushes it to the side. And the old valve actually acts as an anchor to anchor in the new valve. All right, next slide, please. Yep. So this is the Edwards valve. The newest iteration of Edwards valve is what we call the Resilia valve. It's actually some technology that we've had in open heart surgery and is now available for TAVR. It's got 4 different sizes, which is amazing because it helps to treat all of the vast majority of our patients. And having the different sizes again we need based on anatomy and based on the results of the CT scan. Next slide, please. A Medtronic valve. We also have several different sizes. The kind of the blue device at the bottom is actually the delivery catheter, and that's how we deliver the valve. The newest one we're using is Evolut. It's actually Evolut FX. And again, comes in different sizes, so we can treat a wide variety of patients. Right. So again, when we're looking at sizing, the CAT scan is extremely important. The CAT scan is going to take all the measurements that we need about the size of the aorta, the size of the sinuses, where the coronary arteries are, and all this plays into us picking what valve we're going to use and what size valve we're going to use. In addition to the CAT scan, we also do a cardiac catheterization before we decide on the valve that we're going to use. The cardiac catheterization is a way for us to look at the heart arteries and ensure that there's no blockages. If there are blockages, that can impact how we deliver the TAVR valve. And in some cases, if there's severe blockages, we need to consider open heart surgery, where we would surgically replace the valve and then do a bypass of the coronary arteries at the same time. So this is a nice slide. This is the Edwards valve, which is a balloon expandable. And we'll play the video here in a second. You can see the valve is crimped down on a balloon. And then once we're in the right spot, we actually slowly inflate the balloon with manual inflation. And you'll be able to see the valve, once we're in the right spot, slowly inflate as the balloon inflates the valve. Once it's fully expanded, that balloon actually comes out and the valve stays in place. The valve gets anchored in by the old valve that was failing, by the native heart valve. And this is what it looks like afterward, a fully expanded valve right in the position where we need it to be. All right, and next slide, please. And this is a Medtronic valve, which is a little bit different because it's a self-expanding valve. So instead of having a balloon that we use to inflate it, once we get in the right spot, we actually slowly unfurl or slowly deploy the valve. It's almost like a flower opening. And so it's a slower process, which isn't good for all patients, but in most patients, it works very well. And if you go to the next slide, we're going to see the valve slowly unfurl in the right position. And we use we use several different injections with contrast to make sure that we're in the right spot. And then once we get the valve ready where we want it to be, we actually release the valve. So it sits inside the aorta. And again, it's anchored inside the existing valve that was failing. So in terms of complications for TAVR, there's a lot of potential complications, and that's why we do a lot of testing, including the CAT scan and the cardiac catheterization beforehand. We don't want there to be any surprises on the day of the procedure. And with all the testing that we do, we have a much higher chance of being successful. Vascular complications used to be much higher up on the list, but now when we do a CAT scan, we can actually take measurements of the arteries in the leg so we can make sure that they're healthy enough to undergo a TAVR procedure. That being said, there's still a chance that there can be a small tear or an injury to the artery. Stroke on average is about 2.4%, which is significantly lower than what surgical aortic valve replacement stroke risk is. That's also been lower with the newer iteration of the valves that we use. In the last 10 years, it's amazing how much technology has advanced and how much better each new generation of valves has been. We always worry about contrast-induced nephropathy. The contrast that we use can be toxic to the kidneys. So any of our patients who have poor kidney function beforehand, we do what we can to use a little contrast and also give maybe extra fluids to help flush the contrast out. Heart block is probably the most common complication that we see. When we put in a new heart valve, whether it's with TAVR or a surgical aortic valve replacement, where that aortic valve sits is right by the conduction, one of the conduction parts of the heart. And that new valve can kind of impinge on that conduction system, leading to low heart rates. Most of the time, the heart rates overnight pick back up, but anywhere from about 2 to 15% of the time, the heart rate stays low to the point where we have to put in a permanent pacemaker. Now, with TAVR, recently it averages probably around 4%. The 15% was our initial generation of valves that we used, and it was much higher back then. And then finally, the most serious risk would be any conversion to open heart surgery. And that would be if there's a problem with putting in the new valve or damage to the heart or damage to the aorta, and we have to convert a TAVR to open heart surgery right at the same time. Historically, looking at national averages, the data is around 1.2%. Here in Mount Carmel, it's much lower, it's half of that. But that's why we have a heart team that works together. And when we do the TAVR procedure, there's always an interventional cardiologist, an anesthesiologist, and an open heart surgeon doing the procedure. So that way we're ready in case anything needs to be done. Now, infection is more of a long-term risk that we worry about. Anybody who has active infections, we don't do TAVR and we don't do open heart surgery. We wait until the infection's been treated. It is rare that an infection can spread to a TAVR valve or a surgical aortic valve replacement, but we're very cautious with patients who may need to undergo other procedures down the road, and sometimes even given prophylactic antibiotics so that we reduce the risk of potential endocarditis. And then again, finally, hemodynamic valve deterioration. We know that mechanical surgical aortic valve replacement is the only valve that will last forever. When we do open heart surgery or the TAVR, these valves last about 10 years on average. And again, not from anything patients are doing right or doing wrong. It's just the way the valves are made. And about 25% of valves, of TAVR valves at 10 years fail and need to be replaced. But again, that's why we do all the testing beforehand, so we have a plan in place in case the valves do fail. All right, next slide, please. So when is surgery preferred over TAVR? We mentioned both options to patients. Most patients will say, well, I want the minimally invasive one. It sounds like a lot easier recovery, which it is. But there's sometimes we just can't do the minimally invasive option. If a patient has severe coronary artery disease and needs to have a bypass, then such as CABG, then we would do a surgical aortic valve replacement at the time of bypass. If somebody has difficult arterial access, so if the arteries in the legs or the arteries in the arms are too diseased and we cannot get our equipment through them, then we have to look at doing open heart surgery or other options. And then finally, adverse aortic root. So that goes back to the pictures we mentioned before. In some patients, the aorta is just too small to have a TAVR procedure. In that case, we have to do open heart surgery. It used to be thought that anybody with bicuspid valve or patients who are younger should have surgery instead of TAVR. But over the last 5 years, we've actually had randomized controlled trials looking at both of those patient subgroups, and we found that TAVR does equally well, if not better, than open heart surgery. So the indications for TAVR are really changing every year. All right, next slide, please. Now, in conclusion, aortic stenosis, it's a deadly progressive disease, and that's why we've really worked on educating patients, primary care physicians, with what to watch for and to consult cardiology or get the patients in to see cardiology as soon as possible. Then we can start the workup with ultrasounds, get the patient tuned in with our heart team, and get a plan in place. We know that in patients who develop symptoms, we don't want to wait. The longer we wait, the higher chance of leading to heart failure or more permanent damage, which is the last thing that we want. It's amazing how TAVR has been rapidly evolving over the last 10 years and gone from being a procedure only for patients who are too high risk for surgery to now being really an indication for anybody with severe aortic valve stenosis. So we're working as part of the heart team with our primary care physicians to ensure that every patient gets the treatment that they need.
Great. Thank you, Dr. Buschur. So now we're going to open the floor to questions. Now, we did have some questions come up on our social channels, so we can start with those. And if anyone has any questions, please be sure to enter them in the Q&A section. The first question we received is, how often should my physician monitor my aortic valve for changes in its area?
That's a great question, and a lot of that determines on symptoms and also if they already have a diagnosis of aortic valve stenosis. For routine monitoring in someone who does not have any valvular heart disease, then yearly visits with a primary care doctor where they can listen to the heart is acceptable. And somebody who maybe has mild or moderate aortic valve stenosis, we would potentially see them back on a more frequent basis to ensure that they don't have any symptoms, and we would do the ultrasound imaging more frequently. But for someone with no diagnosis of valvular heart disease, a once-a-year visit with their general practitioner or PCP is adequate.
Great, thank you. The next question we received was, should I limit my physical activity because of aortic valve stenosis?
That's a good question, and that's something that each individual patient should bring up with their cardiologist. A lot of that will depend on how severe the aortic valve stenosis is. In patients with mild stenosis, for the most part, we do not have them restrict themselves. We want them to be active because that's how we know if symptoms will develop. Now, in patients who are asymptomatic but may have severe aortic valve stenosis, we'll be a little more cautious with what we recommend them to do, just because even if they're not having symptoms, it can be a lot more stress on the heart. But it'll be really up to the cardiologist and each individual patient.
The next question we received is, how will I know when it is time to replace my heart valve?
Very good question. A lot of that will be based on symptoms. So when somebody starts having symptoms with exertion or even with their normal activities, then we really start the process of working them up to have the plan of replacing the aortic valve. Now, if somebody's not having any symptoms, then we continue to do the ultrasounds where we can closely monitor the heart pumping function and the size of the valve. And that's something we would do routinely even without symptoms.
Thank you so much. We also received a question asking, if I experience dizziness, does that have to do with my aortic valve replacement?
It doesn't have to, but it can, and that's one of the three main symptoms that we evaluate before we put in a new aortic valve. Dizziness, shortness of breath, and chest pain are kind of the three criteria that really concern us as cardiologists and that we want to watch. Dizziness can happen for a lot of reasons, but we always rule out valvular heart disease as part of that initial workup.
One of the questions we received had to do with a diet. Does changing my diet improve my symptoms of aortic stenosis?
Very good question. There's been no data that changing diet will change the progression of aortic valve stenosis. That being said, we do know that patients with poorly controlled diabetes, patients who smoke, patients with high cholesterol do seem to have a quicker progression in their aortic valve stenosis than those patients who do not have those risk factors. So a heart healthy diet, cutting back on the cholesterol, and in patients with diabetes, helping to lower the A1C, in theory, that is going to help slow down or delay the progression of aortic valve stenosis.
Thank you. We received another question that says, I have COPD, emphysema, sorry if I'm pronouncing that wrong, and have all the symptoms you described. How can I tell whether they are heart related or COPD? Yesterday received ECG with sinus rhythm with marked sinus arrhythmia.
Yeah, that's a good question. And ECG is a great tool. It looks at the electrical system of the heart, but it's not necessarily going to tell us anything about valvular heart disease. So in patients who were worried about shortness of breath and we want to do a further test on the heart, we would recommend an ultrasound or an echocardiogram of the heart, as well as a complete physical exam by a cardiologist. We can really assess the aortic valve.
Thank you. Another question we received is this hereditary or is there anything that one can do to prevent it from progressing?
Very good question. So the um, Congenital part of aortic valve stenosis is when somebody has a bicuspid or a unicuspid valve. So instead of having the three leaflets that most of us have with their aortic valve, they're born with only one or two. So that can be congenital. So any of our patients who have a bicuspid or unicuspid valve, we actually recommend that all first-degree family relatives get screened with ultrasounds. Um, in terms of rheumatic heart disease, which again, we don't see as much here in the United States, that's not congenital, but it's from an infection. And then finally, calcific aortic valve stenosis, which is what we see most often, that's not congenital.
Got it. The last question here that I'm seeing has to do with primary care. They're asking if they need to ask their primary care physician to get tested for it, or is that something that they can tell during a regular annual physical?
So most primary care physicians should be listening to the heart. Um, a lot, and what we're looking for is any type of murmur. So as the aortic valve stenosis progresses, we'll hear more and more of a murmur. That being said, listening to the heart in anybody is not 100% perfect. It's a good test, but sometimes there could be ambient noise or other noises going on, and they may not be able to appreciate the murmur as much as what they could otherwise. So if any patient is really worried about it, an ultrasound is a very easy, non-invasive way for us to look at the heart, and the primary care doctors can easily order that to ensure that nothing's being missed.
Great, thank you. Now, I don't see any more questions on the chat, but if anyone joined us a little late, we will be sending out these slides to your email, so keep an eye out for that. And I'll leave this QR here for a couple seconds if you would like to learn more about our heart and vascular team. Dr. Buschur, thank you so much for joining us. I know that I learned a lot, and I hope everyone did too. And again, thank you for joining. I hope you all have a great day.
You're very welcome. Thanks for having me.
Bye bye.